everyone. My name is Richard Hetke, and I serve as the Executive Director of the American Association of Dental Boards, or AADB. We're here today to present our second AADB teleseminar of the year. This program is entitled Dental Therapy, a New Regulatory Frontier. And we hope to deliver at least 2 and possibly 3 more programs by the end of 2018. Before we start, just a few reminders. Our program will run for no longer than 1 hour, and it'll be less than an hour if the questions are few. Time has been reserved for questions and answers. All audience lines are in listen-only mode, and that's done to avoid interruptions or distractions. Now, for those people who've dialed in, first, thank you very much for doing that. Appreciate it. To submit questions for real-time consideration during this presentation, please email your questions to AADB staff member Donna Adler. And Donna's email address is as follows. Dadler, that's D-A-D-L-E-R, at dentalboards, all one word, with an S at the end, dentalboards.org. Again, Dadler, D-A-D-L-E-R, at dentalboards.org. And as soon as Donna receives the questions, she'll flip them right out to our 2 speakers, and hopefully they'll be able to address them at the end of their presentation. Any questions, by the way, that are not addressed within the 60-minute presentation will be answered by email or phone by one of the speakers within 48 hours of this presentation. And for everyone who's dialed in, please tell other AADB members unable to dial into the live presentation today that this program will be available by podcast within about 2 weeks on the AADB Member Resources section of the AADB website. So now I'd like to introduce our 2 speakers for today's program, and we're really happy to have 2 of the real experts in the growing field of dental therapy. Christy Jo Fogarty is a member of the Minnesota Board of Dentistry. She's a past president of both the Minnesota Dental Therapy Association and the American Academy of Dental Therapy. Christy's been a licensed dental therapist for 20 years, and she was the first certified advanced dental therapist, not only in Minnesota, but in the United States. She currently works for a Minneapolis nonprofit clinic that serves underprivileged children and pregnant women, and they've been in business for almost 100 years. Our other speaker, Jody Hager, has worked in the dental field for about 18 years as a dental assistant, a licensed hygienist, and a dental therapist. For 16 years, Jody's worked for a nonprofit clinic providing oral health care to underserved communities. She now works in a rural community in Minnesota, also affected by a shortage of oral health care professionals. Jody has also served as the president of the Minnesota Dental Therapy Association, and she also sits on many advisory committees and councils within the dental profession. So we've got 2 experts here today. So it's time for the show, and I'll turn it over now to Christy Jo Fogarty. Christy?
Good morning. Thank you, Mr. Henke. Thank you for having us on the seminar today. I do want to make one quick correction. I haven't been a dental therapist for 20 years. I've been a dental therapist for 7 years. I've been in dentistry for over 20 years. I just don't want people to misunderstand that. But I will, again, thank you for having us be here today. I just want to talk a little bit. Both Jody and I were in the very first class of dental therapists. We were among the first out there practicing in our state. But we're also both really good examples of career laddering. Both Jody and myself started out as dental assistants, became dental hygienists, dental therapists, and eventually sought certification to be advanced dental therapists. So really good example of what CODA is looking for and kind of hopes to find, and a really good example of how you can continue in dentistry and make more and more of an impact in your communities. We're also a good representation of both rural and the metro area. And Jody has now moved into a rural practice or it's a private practice after coming out of public health. So we really have a good diversity in our backgrounds, and hopefully that'll be able to help us provide some good information to all of you today. What we plan on discussing today is, excuse me, We want to provide you with a brief but thorough history about dental therapy and how it came to be in Minnesota. We also want to help define what a dental therapist is, an advanced dental therapist, what our scope of practice is, and what a collaborative management agreement is, and how that works to make all of this come together for us. We'll also give you an update on the most relevant statistics for dental therapists and advanced dental therapists that are working in Minnesota. And we also want to discuss with you the positive impact that we're having helping increase access to dental care in Minnesota, but also talk about some of the challenges that we face as both Jody and I entered the dental field 7 years ago as dental therapists. So with that, I'm going to hand it over to Jody. She's going to talk to you a little bit about the history of dental therapy.
Thanks, Christy, and good morning and maybe good afternoon. Thanks, everybody, for tuning in. And again, I'm going to give you just a brief history about dental therapy. Back in 2000, the Surgeon General's report on oral health identified barriers to access to dental care. This was the first time this was addressed nationally. And this report identified barriers to oral health care and oral health disparities among our most vulnerable citizens, including poor children, the elderly, and many members of racial and ethnic minority groups. So in 2003, they did a follow-up report. And this was basically a national call to action to promote oral health, which reinforced the 2000 report and named specific actions that needed to take place. One of these actions included increasing the oral health workforce capacity to supply dental professionals to shortage areas, such as in rural and urban areas with racial, ethnic, and poorer populations. In 2015, the U.S. Department of Health and Human Services released a report that projected an increase in the demand for dentists nationally that won't be met by the increase in supply. So what they estimate is that the supply of dentists in 2025 will be about 202,500, while the demand will be about 218,000. This creates a shortage of about 15,500 dentists nationwide. This will affect all 50 states and the District of Columbia. And here in Minnesota, our Department of Health has also identified this growing concern. It's prompted us here in Minnesota to start the Minnesota Rural Oral Health Task Force, which I had the privilege of sitting on last year. And we were really kind of trying to put our heads together to figure out kind of innovative ways to address this growing concern. So amid all of these reports, in 2009, Minnesota passed legislation for a new dental professional. It had the support of more than 50 organizations, including the American Dental Hygiene Association, the American Public Health Association, the American Association of Public Health Dentistry, and 2 charitable trusts. And this profession was created to help improve access to quality dental care for an increasing number of underserved Minnesotans. And I'm really trying to stress the word quality, because one of the things that gets brought up to me often, and maybe Christy can attest to this too, when we get asked to go around the country and talk about dental therapy, one of the concerns and one of the comments that gets made consistently is that the patients that we see are not receiving the same quality care that they would receive with a dentist. And here in Minnesota, that's just not true. We are required here in Minnesota, dental therapists are required to be trained to the same level as a dentist for what's in our scope of practice. So when I see a patient and I'm doing a filling on that patient, I have to be trained to the same level and provide the same quality care as Dr. Brown, who I work with right next to me. So the organizations and individuals that were responsible for the dental therapy legislation wanted to make sure that the people that needed this got it. And so they presented this legislation, which does limit, here in Minnesota, it limits dental therapists' patient base to primarily lower income, uninsured, and underserved patients. And this includes anybody that's living in a dental health professional shortage area. What we're facing here in Minnesota, which I think is nationwide from what I've been hearing, is that we have a lot of dentists in rural areas, private practice dentists, that are looking at retiring and just have not been able to find new dental grads to come out and work with them, possibly and potentially buying into their practices. And for many patients in rural areas, even those with private insurance, it can be difficult finding a dentist that they can see. And so this puts them in that category of underserved patients. 50% of our patient base has to be considered underserved, lower income, or uninsured. Another thing to note is that therapists do not practice independently. I cannot go out in a rural area and open my own clinic free from a dentist. I can't do that. We are required to enter into a collaborative practice management agreement with the dentist, and this ensures the dentist remains the leader of the dental team. I'm going to turn it back over to Christy. Who's going to share with you a little bit about what dental therapy is and our CMAs and that kind of thing. Thank you.
So you're going to hear Jody and I quite frequently stressing many of the same things. So I'm going to help kind of define what a dental therapist is and what our legislation looks like a little bit. So a dental therapist is a licensed oral health care professional who works as part of a dental team. We perform many of the same tasks that both dentists and dental hygienists do, making our scope of practice kind of unique. And as Jody said, we work with the uninsured, low-income, underserved populations to help them have access to necessary dental care. And in Minnesota, our legislation actually provided for two providers, a dental therapist and an advanced dental therapist. So I'll go over the requirements for both. A dental therapist is required to complete an accredited program ending with a master's or bachelor's degree and will always have indirect supervision. The University of Minnesota trains several classes of dental therapists, but it has now moved to a dual licensure program for both dental therapists and dental hygienists, training their dental therapists to be eligible to become advanced dental therapists. Their original program did not provide for that. So as a result, there are currently no dental therapists that are being trained that cannot become advanced dental therapists. Currently, all of them can become advanced dental therapists, and we'll get into how that becomes. In addition, the University of Minnesota also created a bridge program that helped former graduates become advanced dental therapists. So they did take care of those few classes that they graduated ahead of time. Their program is 8 semesters long after taking 10 prerequisite classes. So advanced dental therapists are required to have completed an accredited master's degree program. Metropolitan State University was the first to offer this, and it started as a 26-month program, but it's now been condensed down to a 16-month program. They start in January, and the following May, they graduate. You become an advanced dental therapist after the completion of working 2,000 hours as a dental therapist in indirect supervision, and the completion of a certification process. And in the state of Minnesota, that certification process includes having a chart review of several different procedures that you've done, making sure that you're doing good records. It also involves a written exam. And then the final piece of it is sitting down with the licensing and credentialing committee and going through an oral interview. And as a member of the Board of Dentistry, I sit on that committee, and I can tell you it's a very thorough interview, making sure that advanced dental therapists are good critical thinkers and can really handle a situation where their dentist may be hundreds of miles away. So what this does is it allows dental therapists to work in non-traditional settings. So I just want to also go through and define real quick, because I know in different states, and I know people may be listening from different areas of the country, what supervision levels are in Minnesota. So direct supervision for us means that the procedure needs to be done with the knowledge and the consent of the dentist in the office while the dentist is present, and the dentist has to check the procedure before the patient is dismissed. Indirect supervision, which is what dental therapists work under until they've achieved that credentialing for advanced dental therapists, the procedures need to, again, have the knowledge and consent of the dentist, and the dentist needs to be present in the office. So general supervision, again, needs to be done with the knowledge and consent of the dentist, because as Jody said, we work in collaboration with, we don't work independent of dentists. But the dentist is no longer required to be in the office, or the dental therapist is no longer required to be in the office, which is very common for myself, that I am at an off-site and not at our headquarters office. So what exactly can we do, right? So now you know what our education requirements are. Our scope of practice includes fillings in both the primary and permanent teeth. This includes back and front teeth, it includes silver fillings, it includes tooth color fillings, it includes things like Fuji. We can do stainless steel crowns on permanent and primary teeth. We can do a soft reline of dentures. We can do the stabilization of reimplanted teeth. We can create and place space maintainers. We can do pulpotomies, and if there's anyone on there on the line who is not a dental professional, that's kind of like a baby root canal. We can do extractions of primary teeth. That's all within the scope of what a dental therapist, again, that needs to be an indirect supervision where a dentist is in the office. Once you get that advanced standing, you can do all of those procedures, and in addition to that, we can extract permanent teeth that are mobile due to periodontal disease. So they have to have a class 3 or 4 mobility for us to be able to remove them. Most importantly, probably, is the assessment and treatment planning that we can do. And then there is something in our legislation that talks about dispensing medications, and that is something that we're authorized to do under our scope of practice, but I like to always make it very, very clear to people, we do not have prescription privileges in the state of Minnesota, so that is not something that we can do, only if the medication is available in the office for us to be able to dispense it. But the most important thing that we get in that advanced scope, again, is that general supervision. Once we're finished with our education, before we can gain licensure, we do have to go through a board. Up until this point, we've always taken credit. The exam's given over 2 days, but starting in 2019, the CDCA has also created a dental therapy exam, and that will also be given. Currently, there is no written board that is given to gain licensure for dental therapy. But back to our exam that we do take, the first day is done on a mannequin, much like dentists do. We just have different procedures that we do. We do a pulpotomy, we do a stainless steel crown prep, and we do a crown prep for both an anterior and a posterior tooth. So that's what we do on our mannequin. The second day is clinical testing, and this testing that's done by the GTs is the exact same clinical test that Credis and CDCA give to their dentists. So it consists of doing 1 class 3 filling and 1 class 2 filling. So when we are in that exam, the examiners do not know if they are looking at a dental therapist prep or a dentist prep. So as Jody said, we are required to do our scope of practice to the same level of the dentist, and we're tested in the exact same way. So what brings all this together, right? We get licensed, we get our credentialing, and then we come to work. And before we can start day 1, both dental therapists and advanced dental therapists must be entered into what's called a collaborative management agreement. And you will very frequently hear dental therapists talk about their CMA or their CMA dentist, and that's the dentist in which they are in with this agreement. So it's a very common terminology for us to talk about our CMA. That agreement has to be with a dentist who is licensed and practicing in the state of Minnesota. And that collaborating dentist accepts the responsibility for all of the services that are authorized and performed by the dental therapist pursuant to that agreement. And what we mean by that is that it's a multi-page document, and it really lays out the who, when, where, and why. And I can give you an example. When I first started out, Jody and I were these brand new practitioners out, right? People weren't quite sure how to incorporate us. And one of the things my collaborative dentist management, because I work in pediatric dentistry, wrote right into our agreement was, I don't want you to see children who have a history of being uncooperative. So that's one thing that the dentist and the therapist can sit down and do as they write this collaborative agreement is what am I comfortable with you doing, what am I not comfortable with you doing. And of course, as the years have gone by, and by the time I became an advanced dental therapist and signed my first collaborative agreement as an advanced dental therapist, all of those restrictions were lifted, and the dentist that I worked with wanted me to work to the very top of my license and do my full scope of practice. And we find that that's very common once dental therapists have reached the point where they've gained certification, is there's a good understanding, because that collaboration is so close throughout those 2,000 hours that they really come to understand and trust their dental therapist. But occasionally we will see some restrictions on that first dental therapy collaborative management agreement, and that's exactly what it was designed for. It was really designed to help bring them together as a team. So you'll find that that's a very close working relationship. So now that we're working, I'm going to let Jody move into kind of what that can look like and what those performances can look like.
Yeah, okay. So we have, through the Minnesota Dental Therapy Association, we have a number of statistics that I could share with you today, and we tried to narrow it down and just kind of focus on 4. I'm going to share with you the results of 3 case studies that were done here in Minnesota, and then just some statistics that were submitted by one of our dental therapists who works in the metropolitan area. I do want to stress that in no way do any of us believe that the gross production of dental therapists is the only point that should be made, but I think it is an important point because another concern that a lot of people have is that having dental therapists in the clinic can't be profitable. And so having these case studies done does help a lot. I'm going to quickly summarize them. The case studies, the 3 case studies I'm going to share with you were all done by the Pew Charitable Trust and can be found on their website. So and rather than get into real detailed information because they're kind of long, I'm just going to kind of try to quickly summarize them. The first case study was done actually on myself, and it was done over the years of 2014 to 2016 while I was working at Apple Tree. And they found that a majority of the services that I provided, approximately 64% over that three-year period, was restorative. I did do about 17 to 18% on average in diagnostic. And because I'm dual licensed, I'm both a hygienist and therapist, I did do a lot of preventive work as well. And also what they found was that my average gross production per day was 94% of the average of the dentists at the Medalia Center. And in fact, in 2016, my annual production was over that of the dentist. My gross production per visit was between 8 and 15% less than what the dentist did. And because I'm just telling you, I don't make 85% of the dentist's wages. And so as a result, with the lower employment costs, this was a really good fit for the Medalia Clinic. The next set of numbers I'm going to give you are from Michelle Storley. She's an advanced dental therapist that works with Dr. Ahmed in Diamond Dental, which is a critical access private clinic in Northeast Minneapolis. And what she did is just basically shared some numbers for her stats for 2017, and then she did share just a couple random days in January to give us just a quick view of what a day was like for her. So she picked January 24th and 25th in 2018. Both days she saw 13 patients and averaged about $475 per visit. Her daily production was about $6,250, and she saw largely, again, 77% on both days of restorative care. In 2017, she saw 2,586 patients and averaged about $408 per visit, and her total production in 2017 was $1,055,360. The other case study that I'm going to share with you is one that you might be familiar with if you know anything about dental therapy. This was, to my knowledge, the first case study that was really done in the lower 48 on what dental therapy, what we call dental therapy here. And this was done at Main Street Dental in Montevideo, Minnesota, which is a very small rural clinic in kind of the western part of Minnesota. And Dr. Powers, who was a huge proponent for dental therapy, was the dentist at the time. And I do want to add that Dr. Powers recently passed away about a month ago, and we're very sad about that and miss him. He was a huge proponent for dental therapy. But again, this case study has a lot of numbers and a lot of data. And what he had done is he had taken his dental assistant, Brandy, and he had sent her to dental therapy school. And she was in the first class at the University of Minnesota. And when she came back, he was so happy with the work that she was doing that by the time, up until recently, he had 2 dental therapists and full-time and a part-time dental therapist working at his clinic. And he's got a lot of slides in his case study because he shared this before, but the one I like the most, and the one that I really appreciate him sharing, is he also kept track of the numbers that he had of the procedures he was doing during that time that he had therapists working for him. And so from the year 2011 to 2012, which was when Brandy came back and started working, I think it's very, very, very interesting that he shows a reduction in his composite restorations by 45%, but a 23% increase in his surgical extractions, a 40% increase in root canals, 46% increase in implants, and his exams went up by 49% because his therapists don't do exams. So what that means is that by adding dental therapists to his clinic, it freed him up to do a lot more procedures, but more importantly, it freed him up in a small rural area where access is tough. It freed him up to see more people. The last case study I'm going to share with you was done on a colleague of Christy and I's, Heather Lubin. She was also in the first graduating class of dental therapists. And she also worked with Apple Tree Dental. And she worked with a mobile unit in a long-term care facility. And this study took place over 2014 to 2016, again, a 3-year period. And there's just a lot of numbers in this study. But basically, what they found was that she worked fewer days than the dentist. Her growth per day was pretty comparable. And in fact, in 2016, she grossed more than the dentist did. And what they found was that the average daily employment cost of a Twin Cities mobile dentist was about $628, while the average daily employment cost for having Heather there was $406. And so what Appletree found out with this case study was that they were saving annually, they were saving about $52,000. The other interesting note with her is that, again, she did see a lot of restorative care. Majority of the care she provided was restorative, but because she is also dual licensed, she was also able to see almost 30% of her services were preventive. She does a lot of cleanings and stuff in those long-term care facilities. All right, so we're going to turn it back over to Christy.
All right. So I'm going to talk to you a little bit about some of the things that we've seen that are working really well. Obviously, we are seeing a tremendous increase in access to dental care in the clinics where dental therapists are providing care. Another thing that we're seeing that's working tremendously is just patient acceptance and patient satisfaction, especially when you start talking about like the rural areas where Jody works. You know, nurse practitioners and physician's assistants have almost replaced the primary care physician because they struggle so much to get physicians and dentists out to that area, that when you go in and talk to them about a dental therapist and it being what some term a mid-level provider, they're very familiar with that concept. They're very comfortable with that type of a provider. They know that that provider is going to give them good quality care because they've experienced it already for years. So especially in the rural area, there wasn't even any kind of a question whether or not they would accept this type of a provider. I myself have been in the metro area, and in 7 years of practicing as a dental therapist, I have had one incident where I had a mother say, I really much prefer my child see a dentist. And in our clinic, that wasn't any kind of a problem. I was actually still completing my 2,000 hours as a dental therapist before coming certified as an advanced dental therapist, and I just simply switched patients with the dentist that was my collaborative management agreement dentist. So overall, we're seeing tremendous, tremendous acceptance. We also, as Jody just went over, the production, dental therapists have consistently met or exceeded production goals. They keep pace with the dentist, which I think is also incredibly important. You can look at the dollar signs all you want, but how much time we're spending per procedure and the number of patients we see in a day is very equivalent to the dentist, which helps keep the flow of the office going. And that's the biggest reason why you're seeing expansion of access to care is because you're able to see more patients in a day. And as Jody also talked about, many are dual licensed. In fact, going forward, all of us will be dual licensed unless another program decides to open in Minnesota. As of right now, both programs, one requires you to be a hygienist to get in, one requires that you be both a hygienist and a therapist when you matriculate. So all of us are dual licensed, which gives us tremendous flexibility. I know myself, it's not uncommon for me to do, a couple fillings, an exam, a fluoride treatment, a cleaning, and have the patient be done, and they're welcome to come back in 6 months, where if I had to refer that back for the cleaning, it would be a little bit challenging. We also get a lot of good response from the dentists that we work for about the quality of our care. In fact, I have a couple quotes here from dentists that Jody has worked with. One of the quotes says, practice with dental therapist Jody Hager has been enriching these past 2 months. Her compassion for her patients and attention to quality care demonstrate a strong and positive complement to the dental profession. And Teresa Johnson, who I believe was Jody's first CMA dentist, really nails it on the head here when she says, Jody provides consistent, high-quality, and efficient dental services to her patients. Jody's presence allows me to focus on more complex treatments while she provides the bulk of the routine restorative services. In this way, we team up to see more patients in less time. And that's kind of what Dr. Power's analysis showed is everyone gets to work to the top of their license, which allows more patients to be seen and more procedures to be done, and those most in need, those most needing access to care are receiving more care. So what are some of the challenges we face? Well, Jody and I have been there since day one, so we certainly know that one of the challenges we faced was credentialing and reimbursement. It's getting better. More and more often I'm getting paperwork to be credentialed, but there is no clear, consistent policy for credentialing and paying dental therapists by insurance companies and claims administrators. It's a case-by-case with every single provider. The state of Minnesota, if you have straight MA coverage through the state, DTs can bill straight there, ADTs can bill straight to the state. But currently in many offices, myself included, dental therapy services are still billed through their CMA dentist, and that's at the request of the insurance company. So we're still finding some problems there. And just as a side note, just so if people ask the question a lot, reimbursement rates from the state are paid at the same level as a dentist for procedures performed by dental therapists. Another challenge that we do occasionally face is treatment planning, especially in an environment like mine where we have 5 dentists and 7 dental therapists. Changes to existing treatment plans have to be approved by the CMA dentist, and depending on how your collaborative management agreements, this can kind of interrupt the flow of the day. So we still work through those kinds of challenges. Most offices find different ways to handle that. And there's always the problem of standardization between dentists. In a private practice, if dentists disagree, they just practice the way that they want to practice. When you're working with a dental therapist, you may have a dentist who is not in collaboration with that therapist actually do the exam and treatment plan, but the dentist who's the collaborative management agreement dentist disagrees with that treatment plan, but the therapist is required to do the work. So sometimes that can be a little problematic and requires a lot of communication in the dental team to make sure that those kind of things are worked out. And obviously just a little bit of consistency with dentists and dental therapists and their treatment philosophies. So you really want to make sure that the collaborative dentist and you are consistently talking to each other, working with each other, and understanding, that you're well calibrated to each other. I know for myself, written right into my collaborative management agreement, is every quarter we sit down and we do just grab 10 random charts that I've done and we do a chart review to make sure that we still are on the same page. And as new things emerge as more common practice, like silver niamide fluoride, that we're on the same page as that and that we both want to approach that in the same way. So it takes a lot of communication, but it can be a bit of a challenge. And we still struggle with people not understanding the difference between dental therapy and advanced dental therapy. When we can operate at our highest level, we're efficient, we're productive, we do great patient care, but sometimes it's hard for people to understand that we have to work 2,000 hours before we can get that certification. And even to this day, our scope of practice can be very confusing. Anyone who's dealt with our legislation knows that we don't think it's the best written legislation. We would never encourage anyone to cut and paste our legislation and put it in another state. One, it wouldn't necessarily serve their needs, and two, there's a lot of wordsmithing we would have done to that legislation to make things a lot clearer. There are many things that are gray areas in our legislation that we struggle with. And then there is always, in that 2,000 hours, there's always the constraint that comes with that indirect supervision of dental therapists. I find that most dentists are just chomping at the bit to get their dental therapists certified as advanced dental therapists because they trust them and they're ready to go with them, but that legislation has that 2,000-hour restrictions. And, of course, one of the last challenges we face is we're still really new. I mean, 7 years sounds like a long time in some ways, but really that's a very new practitioner. and it can still be really confusing. Jody and I are consistently barraged with questions that's just misinformation about the purpose and the intent of dental therapy, who we see, what we can do, the difference between dental therapists and advanced dental therapists, the difference in our educational programs, very confusing to people. I will say, though, that the initial concern with the profession has decreased. We went from the Minnesota Dental Association really adamantly opposing us coming into practice to, the past 2 years we've been invited to be speaker hosts at their annual convention, and we're invited to the table when they're talking about what types of policies would dentistry like to approach together with the Dental Assisting Association and the Dental Hygiene Association, and they have now invited the Dental Therapy Association for the past 5 years to be a part of that conversation. So the more practitioners that we have coming out of the dental school here in Minnesota who went to school with dental therapists side by side in the classroom, and the more that people experience dental therapy for themselves, the more and more acceptance we're seeing. So I'm also going to give you just an update. As I said before, I sit on the board of dentistry, and last month the Minnesota Department of Health gave us kind of their latest snapshot and update of what dental therapy looks like in Minnesota. So as of April of 2018, there are 86 licensed dental therapists in Minnesota. 39% of us are dual licensed. 55% have achieved the certification for advanced dental therapists. We find that the vast majority do seek certification. Dental therapists are relatively young, so that's very encouraging for our field. 55% are under the age of 34, and 84% plan on working for 10 years or more. So that's very encouraging that we have a young, strong workforce out there. And dental therapists continue to be more diverse than other oral health professionals in Minnesota. 12% are Asian, 3% are Hispanic, 2% are Native American, and 9% are multiple races. So we really try and reflect our population as much as we can, and there's a lot of encouragement for that. And then dental therapists are very geographically distributed in proportion to the state's population. And this is a question we get all the time. Aren't all your dental therapists just working in the metro area anyway? They're not even helping the rural population, which is completely false. 55% of Minnesotans live in our metropolitan area, and 59% of our therapists work here. And 45% of our population live in what we call greater Minnesota or rural areas, and 41% of dental therapists work in that area. So we are very proportionate. And this is the first time that we've done this survey where we've had a little bit of a change of practice settings. Traditionally, the vast majority of dental therapists worked in community-based nonprofits, community health centers, FQHCs, hospitals, schools, mobile clinics. That percentage is 47%, so there's still a good percentage of us that are working in those settings. But for the first time ever, private practice has surpassed the number one, and 49% of dental therapists now work in private practice. The remaining 4% work in academic settings. And then, dental therapists also provide services in community and rural settings at more than 370 mobile locations. And that includes Head Start programs, community centers, VA facilities, and nursing homes. So we really are getting to those most in need. All right, and I will just finish up with one of the last things that we have heard multiple times over the years is that dental therapists in Minnesota are having a hard time getting jobs. And again, in the last 2 years, things have really switched around for us. 93% of licensed dental therapists are being employed to the level they want to be, as compared to 74% in 2014. And I think what you'll hear from the Minnesota Dental Therapy Association and from dental therapists in general is there are far more jobs than there are dental therapists right now. There are several positions sitting wide open for dental therapists. We literally can't graduate them fast enough to get them into these positions. So with that, unless Jody has anything she would like to add, I think that we could probably open it up to questions.
Yeah, I really don't. I mean, Christy, you pretty much covered most of my summary. The only thing I wanted to mention, too, is that accreditation. In February of 2016, CODA did adopt a process of accreditation for dental therapy education programs, and both of our programs in the state are working towards being accredited. They're currently accredited through our Board of Dentistry. But yeah, otherwise...
Sorry.
Go ahead.
As I sit on the Board of Dentistry, we are in the process of reaccrediting those two institutions. And I can share with you that the University of Minnesota's dental school and dental hygiene school both are up for reaccreditation in 2020, and they are working with CODA right now to make it that they also get their dental therapy program accredited at the same time in 2020, so that all three, dental hygiene, and dental therapy all are on the same reaccreditation program. So, and they are on time and on track to have that happen. So in 2020, Minnesota should see its first CODA accredited program.
I do also want to briefly mention that in 2013, the Minnesota Dental Therapy Association was formed. And if you are ever looking for good information about dental therapists or have questions or want to contact a dental therapist, our website is www.mndta.org. And also the Minnesota Department of Health put together a toolkit for dentists that are hiring and wanting to incorporate a dental therapist into their practice. And that you can find on their website. And so there's a lot of resources. One thing that we've done pretty well, I think, in the state, there's some resources out there for people that are looking for dental therapists. So does anyone have questions?
Jody and Christy, I just checked with Donna. We don't have any questions that have been submitted during your presentation. That's probably because you did such a good job. But we don't have any questions in right now. So I guess we're just about ready to wrap up the presentation. I want to first thank the audience for dialing in. I thought it was a great presentation. I certainly learned a lot. I'd like to thank our two speakers, Christy Joe and Jody. Learned so much about dental therapy. And I want to remind people who are dialing in, we will have another very, very good session on dental therapy at the AADB annual meeting coming up in September 22nd and 23rd. We've got, I think, a 45-minute session on this very subject. So just kind of a preview of coming attractions. Also want to remind everyone to tell people, to tell other AADB members who couldn't dial in today because they had a patient in the chair or a meeting or a lunch commitment, that this presentation will be available by podcast in about 2 weeks. I guess Donna Adler's come into my office. I guess a question has come in. Christy, do you have you received a question?
I have not received it.
Okay. I will go out and check again with Donna. Just a moment.
I'm sending the question out right now.
Thank you, Donna.
Okay. We'll just wait 1 second here.
Okay, it says, what alternative can speakers provide to licensure board oral exams for licensure? I'm not sure I understand the question. Hang on 1 second. Do degrees, designations, or certifications?
Why don't we just follow up with a call or an email to them?
Yeah, they do have
after the
actually 2
presentation.
questions on here. Yeah,
Okay.
I can answer the second question. It says, do degrees, designations, certificates bestowed come exclusively from CODA accredited institutions? Are there a few non-CODA institutions? why are these institutions not performing oral exams? I can tell you that, as we just said, right now, the 2 programs in Minnesota are accredited by actually the Board of Dentistry, and there are other organizations that do accredit educational programs other than CODA, and that was considered at one point in time, but CODA came up with standards and worked very closely with both of the educational institutions in Minnesota to make that happen, and we're very happy with the results. So at this point in time, the Minnesota Board of Dentistry is not considering another accrediting board, but yes, other accrediting boards were considered, but have not been adopted.
All righty. Well, I guess with that, we're ready to conclude the presentation. Again, thank you to the audience for dialing in. Thank you so much, Jody and Christy Joe. Look forward to the presentation on dental therapy at the annual meeting, September 22nd and 23rd. And this presentation, as I said, will be available by podcast. Within about 2 weeks, we'll drop it onto the AADB website in the member resources section. So thanks again, everybody.
One more question coming in.
Okay.
I'm sending it right now.
I promise not to do my sign-off a third time, so we'll answer. We'll conclude the presentation.
So the question is, what clinical didactic examinations are required for ADT licensure? We do not do a clinical exam for the ADT licensure for that certification piece. Remember, to become an advanced or to become a dental therapist to begin with, you take credits, or now it will be CDCA. So it's given by third-party examiners, just like it is for a dentist. The exact same clinical exam that's given to a dentist is given to a therapist. What we do in that part is we give them a written examination. We also do an oral evaluation where they come in, they sit down through an interview, and in that process we also look through 5 cases of theirs. We look for proper record keeping, notations, referrals, anything that whole complete chart to make sure that they're doing adequate record keeping to the level they would need to do if they were 500 miles away from their dentist, to make sure that there's adequate record keeping, and then that oral interview that really tests their clinical knowledge and those skills that you need to be able to work on your own.
Okay. I want to remind the audience to have any other questions that if you're half as bad as I am, you'll think of your best question tomorrow or the day after. You can still send them to Donna Adler here at the AADB headquarters, and Donna will get them out to Jody and Christy Joe, and they'll follow up with either a phone call or an email. All righty. Thanks, everybody. We're at about 12:50 right now. We brought it in at under 1 hour. Look forward to seeing everybody at the annual meeting in September. And as I said, keep your eyes peeled. We're going to be doing 2 or 3 seminars, additional seminars before the end of the year. Thanks again, everybody, and thanks for dialing in. Bye-bye.